thank you, Professor Farge, for the kind invitation. I want to talk to you about my experience, small and humble, with vaccination. Let me just share the screen. Okay. So we were standing here 2 years ago, and I remember at the evening I was reading a strange manuscript from the New England about a strange virus from China, and I was thinking this has nothing to do with me. Of course, I was wrong, and this had an immense impact on the stem cell transplantation program all over Europe, and we can see the decrease in stem cells transplantation in autoimmune rheumatic diseases in 2020. The EBMT guidelines suggest to weigh the risk of the disease against the risk of the pandemic at each country. And this was all true, but a game changer came to stay the vaccinations. Now, Israel is a small country which has a universal healthcare system and digitized health records, and this made the opportunity for Benjamin Netanyahu, the Prime Minister, to strike a deal with Pfizer, enabling to fast coverage and of vaccination in Israel of mostly all the adult population. And Israel became like a laboratory or an aquarium for all the world in order to monitor the efficacy and the safety of these vaccinations. Actually, we had an 85 coverage of the adult population within 3 months in April 2021. So the questions I'd like to raise are, what is the good time to vaccinate after stem cell transplantation? And should we also monitor the immune reconstitution or just look at the time from stem cell? First of all, we usually use the immunoglobulins as protective, and let's see what is the evidence for that, and can they really be a surrogate marker for protection? So we have one study, pretty large, from Sheba Medical Center, the biggest medical center in Israel. They vaccinated 12,000 healthcare workers in these 3 months from January to April 2021. And they were looking at breakthrough infection in healthcare workers. They had the whole information of antigens and antibodies for 22 cases that had a breakthrough infection, and they compared it to 104 matched controlled age and sex. And let's see the results. We can see that in the cases with breakthrough infection, they had a lower immunoglobulin titer than the healthy controls. And they also could demonstrate a reverse ratio between the concentration of the immunoglobulins and the viral load. So I think we can rely on this study to suggest that SARS-CoV-2 antibodies should be considered protective and a surrogate marker for immunity. Let's see, what do we know about vaccination in autoimmune rheumatic diseases? What is the efficacy and what is the safety and the effect of DMARDs on vaccination? So again, a large study, this time from Tel Aviv Medical Center, around 700 cases. And we can see that 86% had been able to mount humoral immunity. And the main factor for not mounting humoral immunity was rituximab treatment. Another study from Haifa, a multi-center study from Rambam and Carmel, and we can see again the same numbers, 86% were able to mount humoral immune response. Looking at the two studies, we can see that with rituximab prior treatment, we had a decreased proportion of patients getting to have a humoral immunity, around 40 or 50%. The time from rituximab treatment is also important. We can see that the chances of getting humoral immune response in the first 4 months are slim, getting higher and higher between 4 to 6 months and further on as we get away from rituximab treatment. This is a study from Vienna, the group of Joseph Smolin, and they were also able to see that in autoimmune rheumatic diseases, patients who received rituximab and did not have B cells were not able to mount humoral immune response after vaccination. And the patients who did mount humoral immune response had regression, which is as the more you have B cells, the more chances you can get higher antibody levels. So there is a correlation between B cells and the chance to get immune response. What we conclude from this is that 86% of patients with autoimmune rheumatic disease mount humoral immune response. Anti-CD20 treatment impairs humoral response, and there is a correlation between CD20 numbers and antibodies titers. But do we need also T-cell response in order to mount a response? Let's look again at the study from Vienna, and we can see that among patients who did not have T-cell response, only 13% could mount humoral immune response. And from that, we can deduce that it is highly unlikely to mount humoral response without T-cell response. Okay, with that information, let's look at the safety of vaccines in autoimmune rheumatic disease. First, let's look at patients from the COVAX registry of EULAR. This is with various autoimmune rheumatic disease. And we can see that overall the safety is very similar to healthy controls. 37% had adverse events. And what's interesting here is, there are some suggest what we call ASIA syndrome, and they ask if there is a chance of exacerbation of autoimmune rheumatic disease after vaccination. So in this very large study, we can see that only 4% had exacerbation of autoimmune rheumatic disease. We don't have a control arm for this, but this is a very small proportion that we expect to see anyway in patients with autoimmune rheumatic disease. Not everyone is stable. More specifically, around 1 week ago in Lancet Rheumatology, the SPIN cohort. This is from Jessica Gordon, New York, a multi-center study, also from France and UK. And this looks specifically at patients with scleroderma. And we can see that 4%, 6% or 8%, depending on the first or second dose, had systemic sclerosis-related symptoms worsening. Most of them were not very specific, like fatigue and muscle weakness, but some had exacerbation of Raynaud phenomena and arthritis. So this looks not bad, but there are some patients with exacerbations. But we should always remember that as the vaccine may exacerbate the disease, probably this patient would have also an exacerbation with the virus itself. So the trade-off is still good. This is a report we had of a patient with a very quiet systemic sclerosis limited for 17 years, who after a COVID-19 infection, which was not very bad infection, had a renal crisis, which was very unusual for a patient with anticentromer 70 years after start of the disease. Now let's look specifically what's happening after stem cell transplantation with vaccination. We have 3 registries, one from the UK with 38 patients with what's interesting in our case, autologous stem cell transplantation. Again, the same magical number, 84% were able to mount humoral immune response, and rituximab was the most influencing factor for not mounting humoral immune response. Only 20% of patients could mount a response. Another study from Spain, the same number, 85% were able to mount humoral immune response. And the last study from Italy with the same number of 87%. Now let's look more specifically at what we saw in our patients with scleroderma who had stem cell transplantation. So we've been able to look at 7 adults who underwent stem cell transplantation and were vaccinated with 2 Pfizer vaccines between January and April 2021. IgG titers were looked at 2 weeks after the second vaccination. The mean age of the patient was 50. All patients received a regimen of conditioning with cyclophosphamide, 3 patients with reduced dose due to cardiac involvement. We can see the time lapse from HSCT to vaccination, which varied from 60 months to 3 months. And all patients could mount good titers of anti-SARS-CoV-2 IgG antibodies, except for 1 patient. This patient was 3 months after vaccination. She had a good CD20 or CD19%, but a very low CD4%, 95 overall absolute. The healthy controls had 100% good vaccination with good titers of IgG antibodies and normal CD20 and CD4 numbers. And a follow-up vaccine at 6 months for the patient who could not mount humoral immune response. At that time, she had a CD4% of 230, was positive, and she had an IgG titer of 5,000, which did not decrease even 5 months after vaccination. The safety was good. None of the patients had a breakthrough infection. Only 1 patient had fatigue lasting for 2 days, which is not unusual. And mostly important, no exacerbation of systemic sclerosis happened after vaccination. Overall, we can say that SARS-CoV-2 vaccination from a very small experience seemed to be safe and effective following stem cell transplantation for scleroderma. Humoral immunity is achieved in 86%, which is very similar to other autoimmune rheumatic disease, even without stem cell transplantation, and also for hematological malignancies. And the EBMT guidelines suggest to have a vaccination 3 months after stem cell transplantation. We suggest also to look at immune reconstitution and to have a detectable number of CD19 and above 200 cells per millimeter of CD4 T cells, we think these are needed to mount humoral immune response. For the future, it's interesting. Dr. Hennes talked about the cardiac safe regimens, and I think it would be interesting to look at the gaining popularity regimen of Richard Burt with rituximab within it, which probably will impact our opportunity to vaccinate patients and should be considered also as a factor. So this should be looked separately in the future. With that, I thank you very much. This is a video from Jerusalem today. This is called the Deer Valley, and I hope we can elegantly jump around the coronavirus as these deers jump around the river. And I thank you very much from Israel. It's been a pleasure.